all those who have sent their cases. Thanks again for sending in your cases. And the panelists and the attendees, again, thanks again for joining in. Without further ado, I think we have around 9 or 10 cases today. We'll start off with our first case from RCH Bangalore. Over to Dr. Rashmi and Amina.
So this is a 9-year-old girl child. She was referred as absent seizures by her pediatrician. And then luckily she had an episode in front of me in clinic, but it was not a typical absence at all. She just stopped what she was doing. She was staring a little bit, and then she had a lot of little drooling, and she pulled her mouth as if, without even recognizing that she was doing something like that. And then her mother had to take her and wash her face, and she was completely unresponsive. So I thought these are not absent seizures. So then we recorded the EEG. Initially, in this awake and hyperventilation, we didn't get anything. So we went on recording, and finally, during sleep, we got left frontotemporal sharp waves. So then I started on Rivaroxaban and thinking it's probably focal seizure, frontal lobe epilepsy, and then asked for an MRI brain scan.
All right. Amina, over to you.
Yeah. So let's look at the MRIs. The top 4 images are flare images. The middle row is T2 weighted images with the last image of susceptibility weighted image. The bottom shows diffusion weighted and T1 SAG image. So we can see a peripherally located lesion in the left frontal lobe, predominantly involving the orbitofrontal cortex and extending into the left subcortical region as well, almost reaching the ependyma of the left frontal horn. Interestingly, the lesion is so bright, so hyperintense on T2 that it almost appears cystic. And on the flare images, there is near complete suppression. There is also a bright flare rim around the lesion. And on the SWI images, there were no calcifications or hemorrhage. There was no diffusion restriction. And other points of consideration are that the lesion had no to minimal mass effect and no satellite lesions, no other features. Next slide, please. So these are T1 axial T1 post-contrast images showing that the lesion is T1 hypointense and shows no enhancement, neither nodular nor cystic. The MR spectroscopy shows a choline peak, and the left bottom image of T1 SAG post-contrast images is particularly interesting because on the anterior part above the lesion, it appears that there are few areas of cortex along the inner margin of the lesion as well. The possible differentials in a 9-year-old kid with possible left frontal focal seizures probably be discussed by Dr. Nihaal. Over to you.
So these are the differentials I think put on the Excel sheet. So Dr. Rashmi, considerations were arachnoid cyst, traumatic, and epidermal cyst.
So there is no history of trauma. We literally cross-questioned the patient. So there's never been a history of trauma. So we considered arachnoid cyst. Epidermoid cyst we thought was unlikely because of what Amina has described.
Okay.
So arachnoid cyst we were thinking, and Amina has another interesting differential.
Yeah, I think it's
I kind of agree.
Yeah, okay.
Yeah, Amina, so good.
Yeah, please go ahead. I think the DNET is an important differential and would come first in the list. So.
Yeah. I kind of agree with Amina, Rashmi. If you see, look at the cyst of the flare sequences. This is not completely CSF intensity. If you look at the ventricles, this is completely dark. Whereas if you look at this, the cystoia is slightly grayish in intensity, and you have these thin septations within the cyst, and this bright flare rim sign, which is kind of noted for a DNET of a glial neuronal tumor. And then if you look at the contrast, also, I'm not sure if it projects properly, but again, you see some areas of thin septations within the cyst. So that, and with the choline peak and the bright rim sign, and with incomplete suppression on the flare sequences, I wouldn't think that this goes with a arachnoid cyst. Epidermoids would have a diffusion restriction, which is not there. Traumatic, as you have mentioned, there's no trauma and there's no SWA sequences showing the blooming. So particle-based glial neural lesion is what I also thought as a prime consideration for this type. Yeah, the case is open. If anyone else wants to add anything, and if Dr. Rashmi, if any other
so Amina was saying that this could be DNET. Do you agree, Dr. Nihaal?
Yeah, that's what I meant. Glial neural tumor, that is DNET, the most correct one.
Okay. Because if it was arachnoid cyst, it would have the same intensity as the CSF, correct?
Yeah, mostly. I mean, common things being common, it should be close to the CSF on the flare sequences. And the separations, this bright cortical rim sign is what we mentioned is not typically seen in anaphylaxis.
So, I mean, in this trial, we have planned to repeat an MRI in 6 months with some CIS images, unless anyone has any other ideas.
If you want to do a CIS image, you can do it right away. I don't think you need to wait for 6 months.
Okay.
The CIS sequence by any, was it by the radiologist or anyone else?
No, the neurosurgeon, initially he thought it was epidermolysis. Then he said, no, it's not epidermolysis, so I'm not going to operate. So we can repeat an MRI in 6 months with CIS sequences is what he said after discussion with his neuroradiologist.
The child may be still seizing if you wait for 6 months. That is one.
Yeah,
so
right.
If they want to do a surgery and they want some other sequence, I think we can do it right away. CIS sequence, they can, I mean, I think they want to look at the boundary of the cortex or look at the intensity of the cyst within it. But as you can see on the flare sequence itself, it does not match the CSF signal. So a low-grade neoplasm is, I think, high in the consideration.
Yes, are persisting, then better to operate because this won't stop till the region is resected.
Okay,
Leads long-term epilepsy associated tumors. So we have to excise them, then only the epilepsy will go. Otherwise, they won't go on their own. They will become drug refractory for no reason.
I see. Okay, fine. Okay, I will discuss it with our neurosurgeon again and see whether we can do the CIS sequences right away and whether he will be willing to operate.
Rashmi, radiologically, I don't think we need a one, but yeah, if the neurosurgery just once again a double check for confirmation, then yes, they can go ahead with the CIS sequence.
So radiologically, you're nearly certain that it's DNET.
I mean, a low-grade neoplasm, particle-based glioneuronal or low-grade glioma are two possibilities. In that, DNET is one of the possibilities in the glioneuronal spectrum.
Okay.
Yeah.
In the side,
Hi, Rashmi.
Yeah.
Hi.
Yeah, hi, Rashmi. Yeah, I agree with Dr. Reddy and Dr. Joshi that, this is a DNET. We see a lot of these. We are at a major epilepsy surgery center. And resection is the best treatment because once you resect, most likely this child will be seizure-free. Otherwise, he'll keep having seizures.
Okay, sure. I will get them back next week and I'll counsel them again. Thank you so much.
Yeah.
Thank you.
Thank you, Dr. Amita. All right. For express in Jaipur, Dr. Ajay is there.
Yes, I'm here.
Yeah, Dr. Ajay, please go ahead. Thanks.
So he's a 4-year-old, otherwise developmentally normal boy. He developed fever, and after that, fever like almost going on. Still, it's low-grade fever going on. Day 3 of fever, he become confused, agitated, and then started having seizures. So he was seizing for almost 15 days. He was in a government setup. He was intubated, but as soon as they tried to reduce the sedation, he continued to seize. CSF initially was normal. WBC was less than 5, protein 40. And intermittent dystonia on ventilator. We just extubated him yesterday.
Okay. So scan was 4 weeks into illness. When was the scan timeline?
So scan like one was done initially. We did not have the images of that, and then like came to us 15 days after. Then we got the scan repeated.
Okay. So yeah, this is the second scan which I have. I mean, you can appreciate some degree of volume loss in the supratental brain. And there are some edematous changes in the subcortical regions along the posterior hemispheres on both sides, involving the paraphalcean region on the parietal lobes, and also the occipital lobes and the posterior temporal lobes on either side. The basal ganglia, especially the caudate and the anterior aspect of the putamen, appear slightly bright. Possibly also in the cerebral peduncles, we have some areas of T2 hyperintensities. In terms of cerebellum, there is again mild reduction in the volume, but no lesions per se or focal abnormalities in the posterior fossa. On the diffusion varied sequences, you can appreciate a mixed type of pattern of diffusion restriction or diffusion pattern. The cortical regions have some punctate or restricted diffusion, whereas the subcortical white matter changes demonstrate facilitated diffusion. The basal ganglia again has very mild areas of restricted diffusion out there, and also in the cerebral peduncles. The main findings here are you have some mixed pattern of edema involving the cortex subcortical regions, also involving the deep brain nuclear structures and the midbrain, with an overall background of volume loss in the brain. SWA sequences, I could appreciate possibly some punctate areas of microhemorrhages in the cortex on the right parietal lobe. As you can see out here in the first 3 sequences, and also over here on the top 4 panels. And on the again, so on the bottom panels again, you can appreciate some punctate areas of microhemorrhagic changes in the parietal occipital regions. I don't think we have a contrast, but yeah, this is a sad sequence. You can appreciate the midline structure are formed, but again, there is some degree of volume loss. I thought there was some prominence of the perioptic sheaths on both sides. And looking at the angio, could not appreciate any significant stenosis or thrombosis on the MIP sequences. Then the child was followed up. Dr. J, if you respond to summarize.
So much like whatever workup, like it was strange for me. Like the CSF was done twice. Both time it came completely normal. Autoimmune encephalitis panel was negative. ANA was negative. CRP-ESR was borderline elevated. 7 days of methylprednisone, 4 cycles of Plex. ANA negative. And it's a little bit like everything comes back negative. I was just thinking like I'm missing something. Is it something different?
No hypertension, right?
No hypertension whatsoever. Still, like we were extubated him yesterday, still low-grade fever going on. It's almost like 5 weeks. We have zero reason for his fevers. We couldn't find it.
And you have some raised inflammatory markers, ESR, CRPs.
Yeah, just like borderline elevated CRP, like nothing crazy elevation. So just a thought question, like, is anything else I'm missing? Anything else we can do for this kid? Like so much volume loss in 15 days, very unlikely. Otherwise, the family says he was completely normal, playful kid, goes to school, he's in a preschool, everything was good before this, everything.
Okay, see,
Autoimmune panel was negative.
Was it a complete panel or?
Just 6 antibodies did we test typically.
Okay. ANA also was negative.
Yeah, ANA was negative.
I think MOG and MSC negative. Yes, herpes, I'm not sure. Doesn't say that.
Oromandibular dystonia?
It's mostly of the limbs, like he has arms, mostly arms and legs, pretty much keeps going on.
Was he on long-term midazolam and was it tapered and stopped? And on fentanyl, something like that, they do have this thing. They respond to clonidine or dexmed infusions in ICU.
We tried clonidine infusion. Dr. Vivek sir recommended that we tried clonidine infusion. Didn't make any big difference. We tried bromocriptine. We give the thiamine supplementations. Didn't make any big difference.
Because if the seizures were continuing with this history of fever, day-3 seizures continuing, most likely, and this in fires, it is known that this basal ganglia changes and this white matter changes do come up late in the illness. The initial MRIs are normal, but the late in the illness, they do show this basal ganglia changes and they do have this dystonia. Mostly what we have seen in our experience is oromandibular dystonia. As soon as they come out from ventilator, they have oromandibular and limb, like faciobrachial dystonic seizures, they appear. But when you do a EEG, the EEG does not show any electroclinical correlate. So they're usually dystonia only. They are not seizures.
Okay. So pretty much like this pattern looks like more like autoimmune, like MOG and like fires or like anything else. Like, have you seen this degree of volume loss in 2 weeks?
Yeah, very much known. Maybe methylprednisolone, given there will be some volume loss.
Okay, thank you.
We have covered vasculitis, Dr. Ajay. HLH is one more query, but I think they're possible, I guess, but the posterior fossa laterally spared. No, we don't have CT bulant. Kiran says breast-like changes possible with underlying systemic condition. Was the chest and abdomen screened?
Chest X-ray was done routinely, just like intubation and all, but that's the only thing we screened for. So slowly recovering, fevers are coming down, seizures have stopped, but like still, I think it's a long road for his recovery. No, EOG abdomen not done, sorry. No history of any drug intake. Like he says, like only like he was completely fine when he developed fever, went to a local doctor, was started on augmentin and some anti-allergic. That's pretty much what he started. Otherwise, no other medications was given. Sure. Anything else I can do for him? Anything else you suggest?
Yes, I think seronegative autoimmune causes interferonopathies. Okay.
Yeah. Thanks a lot, everyone.
No,
Thank you.
I don't think, yeah, thanks. Okay, Dr. Vivek, over to you.
Right. So this is a 4-year-old child who had seen recently, and she had a sort of long history of 4 months with typical pressure symptoms in form of early morning vomitings, which will be treated with antiemetics and IV fluids, will resolve in between, and then restart. And that went on for 3.5 months. And then in the last 2 weeks, she had right-sided hemiparesis, and she also became ataxic, and hence the family brought the child to me. Child was not hypertensive. She did not have any renal nerve palsies, and she had significant truncal ataxia and the right hemi. And there's no history of fever or history of tuberculosis, no history suggests spinal cord involvement, and fundus was normal. There was no papilledema. So just her MRI to discuss and differential diagnose.
All right, you have T2s and flare axle sequences, non-contrast. You can appreciate there is hydrocephalus with some degree of volume loss in the supratentorial vein. And there's a posterior fossa cyst, more on the left aspect of the posterior fossa. Coming down to the flare sequences, I think there's a better appreciation of the T1 sequence, but you can see that there is some widening of the sulcal spaces. And then you have again hydrocephalus. It looks like communicating type of hydrocephalus, but I think SAG will be better to depict that. Yeah. So no focal lesions in terms of parenchyma, maybe a tiny cyst over here in the anterior vermis. Yeah, and some widening of the folial spaces more on the right side. I thought this was pretty helpful. The T1 sequence is a thin cut T1 sequences, and you can appreciate there are some subpial cystic spaces along the frontal lobes. On it, but I appreciate also on the second image out here. You have these areas of cysts out here on both hemispheres in the frontal lobes. No obstructions in terms of the aqueduct, and also the foramen magnum demonstrates no areas of obstruction. Possibly some exudates out here in the interpeninsular fossa. I think contrast will be more helpful. Yeah, spine was done non-contrast spine T2 sequences. You have focal abnormality in the cervical cord. You have this large intermedullary cystic lesion, predominantly cystic lesion in the lower aspect of the dorsal spine. And these are the axial sequences. You can appreciate it almost involves the entire quad and expands the quad at that level. These are post-contrast flare sequences. You have these diffuse meningeal enhancement. You have leptomeningeal enhancement. Some degree areas of pachymeningeal enhancement are there, more centered in the basal cisterns. In terms of parenchyma, I cannot appreciate any focal abnormalities in the parenchyma. On the spinal cord, you have again diffuse leptomeningeal enhancement of the spinal cord. The cervical lesion does not demonstrate significant enhancement, or the lower thoracic lesion demonstrates this focal area of central enhancement. Yeah, so these are the, I think, main findings on the post-contrast sequences. As Dr. Vivek has mentioned, possible differential, I thought diffuse leptomeningeal granular tumor, given that there are the dilated cystic spaces, you have the spinal cord lesions and diffuse enhancement of the leptomeninges, also the pachymeninges, but predominantly you see centered in the central lesions of the basal cisterns. The LGNT to be considered as one of the prime differentials. So yeah, that I'll open the case if anyone has any other further suggestions. As Dr. Vivek has mentioned, TB was negative, and yeah, no issue of TB and no febrile illness also. All right, Let's see, DLGNT, Ramandeep, Yogaraj, infective, neurodegenerative, but no clinical features of infection. SOL.
The entire left cerebellar hemisphere is cystic, na here.
No, that's an extraxal cyst.
But that is, I think that is a second, another pathology. I don't think it's explained by the DLGNT.
No, not the DLGNT, not the DLGNT. That is, I think, an arachnoid cyst.
Arachnoid cyst.
Yeah.
Or for 2-week thing, it is very difficult.
Now, 4 months symptoms, 4 months of vomiting, 2 weeks of signs.
Okay. Yeah, but I think it has spread all over. The prognosis might not be that great.
Yeah, but you don't think there's any chance of us being a chronic infection? With meningeal, I understand that this could be a something else. Because in 4 months, you're not seeing those little Fokker-Robin spaces very clearly. Right? Some areas they have not much.
So these are the ones, Dr. Rani, if you see over here, between the cortex.
They're usually like bubbles all over the place.
Yeah, I think these are the thin cut sequences which we have. I agree the typical carotid stuff is not there, but I think if you see over here in the vermis also, there's a tiny cystic space out there. And possibly these folia also again slightly prominent on the right side. So are these developing changes or not? I think a follow-up scan only will be helpful. But I would put a DLGNT as virologically as top differentials, then maybe TB. But as Dr. Vikas mentioned, I think TB history is not there.
That history might not be there, but there is no fever. There are no systemic symptoms, no fever.
And this looks more neoplastic, like
very localized.
Yeah.
And two discrete lesions, like one in the cervical cord and then.
So I think we need to biopsy the lesion, Dr. Vivek. I think that would be the next step.
Okay, sure.
See if anyone else has. Yeah, the left cerebellar folia, that's fine. It's a chronic abnormality as left cerebral hemisphere, but I think the main findings or the main thing of concern was of the meninges and the spinal cord lesions.
The enhancement in the
so the tumor is predominantly cystic if you see on the T2s. So I think the only solid areas.
I'm talking about contrast.
Yeah. So the lesion is, mostly cystic T2 hypertension. I would expect these areas not to enhance, only the solid portions to enhance. So. Okay, so I think we'll agree that neoplasm to be considered and biopsy is the next step. A high-grade midline glioma is differential. Okay.
Yeah, thanks.
Yeah, okay. Vishal, if you're there, would you?
Yes. Kiran, he's a 9-year-old boy, second issue of non-consanguineous marriage, normal birth and development and negative family history. Actually, he's from a shepherd's family. They have goats, sheep with them at the home and travel to various places. The illness started with fever and pain abdomen lasting for 4 days. On day 5 of illness, he had status epilepticus and referred to our hospital. And at presentation, his GCS was 13/15, and there were no other focal neurological deficits, and meningeal signs were also negative. And at this point, we had our first scan.
Okay, first scan in terms of diffusion, do not appreciate any area of distributed diffusion. This appears to be slightly bright on the hippocampus, but again does not show reversal on the ADC sequences. T2 sequences, again, no focal lesions, no cortical malformations. Very minimal prominence of the circle spaces. But other than that, I don't appreciate any significant findings. Maybe along in the vermis again. minimal reduction in the volume, but no focal lesions, no particle malformations, no acute abnormalities.
And this is the initial EEG which suggested mild to moderate encephalopathy. And after few hours after this, his GCS dropped suddenly to 9 and the child was intubated. In the next few days, he also developed increased ICP spikes. He developed dystonia. Meanwhile, the investigations, his CSF analysis was normal. We sent nasopharyngeal swab, COVID, influenza, and HMPV. It was negative. PCR for tropical fever panel also came negative. And today we got CSF PCR for dengue and chikungunya, got IgM positive. And during the day 6 of illness, it was around last Saturday, he got seizure, 2 episodes of seizures in the form of staring loop with frothing, and it was associated with tachycardia. And his EEG also worsened with time. It showed high amplitude spike and wave discharges in clusters, arising mainly from the left hemisphere, and it gradually progressed to the right hemisphere also. Currently, child is on mechanical ventilation, throwing only electrical seizures and not responding to multiple anti-epileptics. And the second scan also done. It was on 21st.
Okay, second scan, in terms of diffusion, you have some new areas of restricted diffusion, predominantly involving the perisylvan region on the left side. Possibly also the insular cortex on the right, but yeah, main changes on the left, insular cortex, and also the perisylvan region. The brain structure is relatively normal. T2 does not demonstrate the findings. Yeah, the main findings are better appreciated on the diffusion sequences. Post contrast, no enhancement of the abnormal areas, especially along the perisylvan regions, and no areas of blooming appreciated on the GRE sequences. I think the EEG findings have been described. So these are the possible differentials or queries from the team. Are we dealing with post-ictal changes in the MRI? Is there progression in disease, or are there any findings of autoimmune encephalitis? And as Vishal already given out, these are the recent tests. So NMD has come negative and IgM positive for dengue and chikungunya. Vishal, any specific question?
Yes, sir. Sir, this imaging findings, does this fit into chikungunya?
We are treating as and this is Dr. Prerna. We are treating as fires, but we just wanted to know this interval change. Was it mostly post-ictal, or was it is the child starting to show signs of fires type findings on the MRI, or is it just post-ictal changes?
Chikungunya, I'm not sure, Dr. Prerna, at least at this age group. And dengue also are not typical findings of dengue.
We didn't feel it was matching with this. This
fires is a possibility.
Yeah, we are treating him as fires. But then we just wanted to, because actually initially they reported this MRI as normal, and only when we sort of saw the images, raw images, we felt that there was some hyperintensity here.
So fires can have insular.
Yeah.
Sorry, Dr. Nadi.
How many days into the illness?
So now he is, I think, into the second week of his illness, second or third week. So the fever and the seizures actually started while being in the hospital. And prior to that, he was just encephalopathic with a very short history of fever. We don't exactly know because the history is quite unreliable. We haven't done a MOG because of financial, like they're already, because of the EEGs and other things, they're quite strained financially.
Sometimes in the encephalopathic phase, if you do a prolonged EEG, that will be showing seizures. So it's actually not it's the seizures which is causing the encephalopathy. Often we end up just doing a half an hour, 1 hour EEG which shows slowing.
So the first EEG, which was done when the child was encephalopathic, just showed slowing. This was only done so because we were giving intrathecal Dexa and we were giving ketamine and other things. So it was just for that monitoring only, sir. So after we started with the ketamine, there was some response, but it was quite short lasting actually. He's currently on 5 of ketamine. We're planning to increase if it's not working. He's also on keto diet and other things.
Yeah, your
Does
EEG
the-
is very suggestive of fires. The typical fast activity and the
Yes,
spike
yes.
and wave comes is very, very suggestive of fires. So I think you'll have to go in that direction only. You can even consider immune modulation. I mean, anakinra, tocilizumab, and all that, depending on what the ferritin levels are.
We are sort of trying for IVIG and anakinra in case we get it from the government setup because their financial status is not good.
Okay, okay.
In fire, just out of interest, there's been a paper on once in the second, third week, you start getting this capping of the frontal horns. Have you seen that?
No.
So in fact, the capping of the frontal horn is the paper which came out said it was quite specific. I'm not sure it is.
I'm not sure though. Yeah.
Yeah, the capping of the frontal horns, you can on flare images and all that, you get that in fires. Whether that's something which is always happens or happens sometimes and it doesn't happen in other conditions, I'm not sure. But just to ask the radiologists if they've seen that kind of thing.
That's what I think Dr. Nihaal discussed one paper on MRI progression in fire. So it is first week normal, second week diffusion restriction plus minus edema, third week atrophy, fourth week burnout, cerebral and cerebellar atrophy. That's how
But
it
look at this paper. So it's on capping of the frontal horns with this high signal intensity around the frontal horns. According to the paper, they've actually given 3 or 4 grades of fires. Depending on the amount of atrophy and the amount of the thing, you can actually prognosticate. It's an interesting paper. That's into here. I think it may not be very sensitive.
Okay, so consensus, I think we are going with fires.
Yeah.
Send an article to if I can find it.
Yeah.
Thank you, sir.
All right, Vishal.
Yes. Nagesh is a 11 years old boy, second issue of third degree consanguineous marriage. He presented to us with complaints of ptosis in the bilateral eyes, left more than right, which was acute in onset. He also had double vision with restricted eye movements. He had impaired elevation and adduction in both the eyes. And there was prodrome of fever and vomitings for the initial 2 days of the starting of illness. There was history of trivial traumas present and JE vaccination 2 months prior to this illness. And on examination, there was bilateral ptosis, left more than right, as you can see in the picture. No RAPD. There was restricted eye movements in the form of impaired elevation and adduction in both the eyes. I have the video in the next slide, sir.
Okay, I think I put them. Okay.
This was at presentation.
Okay. I think we had one external. Yeah, sorry, Vishal. Go ahead.
This time they came with the scanner already. This time.
Okay. So we had one external MRI. I just of the T2 axials. And the T2 axials, the main findings are in the brainstem, particularly the periaqueductal region, the dorsal pons, and the dorsal midbrain. Yeah, if you can see on the second panel out here, second image, last 2 panels. In terms of supratemporal structures, I'm unable to appreciate any focal lesions or edema. Cerebellum also had possibly some hyperintensities in the middle subpeduncle, but the cerebellar hemispheres in terms of signal changes and volume appears to be normal. So main changes on the brainstem, and possibly also in the middle supraorbital peduncles on both sides. I don't have an axial post contrast, but even these are slightly pixelated images. Any mention? I mean, very difficult to appreciate. Vishal, anything mentioned in the report? Bilateral optic?
No, the optic nerves were
nothing?
unaffected.
Okay. So just these post contrast sequences. So after that, I think the child was investigated. Vishal, if you can just find out
Yes.
the main findings.
Yeah. As the child was presented with ptosis, we first wanted to rule out myasthenia. We done repeated nerve stimulation test. It was negative. NCV, VP we have done, it was normal. And routine metabolic screening was also negative. His CSF analysis also was normal. And to rule out any spinal lesions, we have done MRI spine.
Okay, MRI spine, I have only the SAT sequences put out here. Again, you can appreciate the brainstem abnormality on the first image out there, but in terms of focal lesions in the spinal cord, I checked the axial sequences. I could not appreciate focal abnormalities. These are, I think, mostly partialing and some movement-related changes. Post contrast, again, there's no enhancement or no lesions in the spinal cord, no enhancement of the caudate and nerve roots.
Dr. Nihaal, was there
Yeah.
any interval increase between the two scans, like if you had to compare?
We don't have a second brain.
Yeah, we don't. I mean,
maybe I don't have a SAG again of the first. Maybe I think it'd be very difficult to say. So, okay. So this is more in the bonds between in the patchy abnormalities. I think very difficult to say without the axial sequences.
okay.
Anything on diffusion? I think I don't think we have diffusion also on the first scan.
We'll be repeating in a month's time, so I think we'll get
Okay.
all those sequences
Fine.
just to see. Yeah.
So Vishal, if you can just
yes. We considering demyelination, we have started IV MPS for 5 days, and in view of partial response, we again started IVRJ also for this child. And this is the video after treatment. He only partial ptosis is present in the left eye, and the rest his eye movements became normal.
So would we think of MOG at all in this, like with the area, like he initially presented with vomiting and things, but then this is not really area postrema, isn't it? It is a little bit higher than that.
Yeah, that's the area postrema. It is higher than that. In terms of MOG, I don't think it's very specific for MOG. I would say infective or early demyelination.
Okay.
Given that the lack of supratemporal findings, lack of optic neuritis, spinal cord lesions, very difficult to call it as MOG, only on radiological basis.
And would you have like radiological changes in Miller-Fisher type?
Miller-Fisher type, but without the enhancement of the cardiac nerves.
Yeah. Okay.
I think we start with the enhancement of the abnormality of the cardiac nerve and then go supratemporally. So this point is lacking out here, at least on these images.
Okay.
Let's see if other
so
people agree.
Dr. Sridhar mentions neurobechets.
Possible, but at this stage, I would say more of a clinical diagnosis than radiological.
Okay.
Yeah, Neurobechet, we have seen one case which presented with just brainstem findings and responded to methyl in this. But we had to give anti-TNF alpha also for long-term remission.
Okay, thank you.
I think comments are mentioned because of brainstem encephalitis, possibly, yes. GQ1B levels, I don't think have been tested. Neurobechets, as she has already mentioned. Steroid responsive indicator of demyelination. Enterovirus, yeah. Yeah, viral infection, I think, yeah. Yeah, MRI at this stage, as Dr. Vivek has mentioned, not suggestive of neuro patients.
Yeah, quite non-specific. Okay.
It has more vascular focal lesions involved into the corticospinal tracts.
Okay. Thank you.
Jayant, you wanted to say something? Sorry.
No, sir.
Okay.
Thank you.
So I think our follow-ups can, Dr. Prerna, if we can get that done, and we can just check the brain and the spine at that point.
Yeah, the GQ1B we will be sending when they come back. Yeah.
Okay. All right, Harika, if you're there, over to you.
This is a 9-year-old girl born on consent admission into neonatal jaundice, and hypoglycemia was there itself, but no documents were there, and normal development. This child had one episode of right focal motor seizure with impaired awareness on 4th April. And after that, no further seizures, and she had developed acute right hemiparesis on 18th of May. And she was taken to local hospital, and they have observed this hemiparesis is improving, started improving within 24 hours. Now, when they came to us, child was coherent operative, extraocular movements, no facial or bulbar, and there is right hemiparetic and right frontal drift was persistent. So outside was admitted for this, and child was evaluated and have come to us for OP.
Okay. So I have the follow-up scan. So this is the most recent one, and you can appreciate there are predominant white matter abnormalities. These are flare sequences, confluent changes, some asymmetry. Yeah, some asymmetry out here, especially in the posterior aspects. But you have predominant white matter abnormalities in terms of flare hyperintensity. T2s again, T2s again, you have hyperintensity is confluent in nature, slightly more on the left hemisphere as compared to the right. Deep brain nuclear structures appear to be relatively spared in terms of the signal abnormalities. Cerebellum also appears to be relatively spared. The brainstem also I do not appreciate any signal changes. There is some degree of parenchymal volume loss. But other than that, these are the predominant changes. White matter abnormalities, confluent changes, slightly asymmetrical, slightly more on the left hemisphere. Post contrast, you have these areas of enhancement, particularly involving the bilateral frontal frontal lobe, perionic regions out there, and also on the left perisylvian region, the insular perinsular white matter demonstrates these fluffy areas of contrast uptake. Optic nerves, I'm not able to clearly see on these images. Anything mentioned of the optic nerves, Harika, on findings, optic neuritis or enhancement?
No.
At least on these images, I'm not able to see. Okay. So again, the child was evaluated. Yeah, sorry. Go ahead.
So this child, evaluated because of this acute onset hemiparesis. Outside they have done CSF, and also outside it was evaluated for seizures initially with CSF where cells were 30 and protein was 22, sugar was 52, and gram stain was negative. And because of this new onset hemiparesis, they have evaluated for demyelination also, where visual fields are normal and EEG was normal. Now, and child has some intellectual issues like memory issues, so for which we have done IQ and social quotient. IQ is 75 and social quotient is 90. And now our question is whether this is like really demyelination, because child started improving. Steroids were not given. Child started improving like within 24 hours. We have sent serum NMO still awaited.
She has been started on steroids after the last OP visit, but initially during the admission there, it was not started.
Ramandeep says ADM OX spectrum, yeah, possible.
The initial MRI was extensive white matter changes, actually bilateral supratentorial. So there was a debate whether it could be leukodystrophic process because there was some cognitive slowing. That's why the IQ was also done. Last 2 years, some others said there was a little bit of slowing inner cognitive process and school performance. But within sort of 1 month, she came after the seizure. She went to another hospital with this hemiparesis, which was transient and improved partially. So when the second MRI was done with contrast, that gave us clue that it's more likely a demyelinating illness rather than any leukodystrophic process. So we sent Morgan Lemo and started treating for the demyelinating illness.
So I think Dr. Lokesh mentioned, radiologically, I think the contrast is kind of helpful for demyelination. Dr. Vivek asked, is it possible for XALD? Not a typical pattern for XALD, I'd say. Posterior hemispheres are relatively spared in terms of enhancement. And also, I think the white matter changes are again more frontal, parietal, temporal, but you can see the right temporal is really spared. Corpus callosum, the splenium of the corpus callosum again really spared. So, leiomyomatosis cerebri, only white matter involvement. I would say that maybe slightly atypical again. Yeah, leukodystrophy variant of Morgan. Yeah, I would agree. Any other possibilities other than demyelination? If anyone wants to comment.
I actually missed the story. Is it an acute story?
Yeah, Rajesh. April had one seizure, and then no further recurrence of seizures on anti-seizure medication. And then May 18th had hemiparesis.
Achha. The second MRI has improved quite a bit.
There's only one. There's only one MRI program. This is the second MRI. So this is flare T2. Yeah, flare and T2s, and these are the contrast sequences.
Oh, no, I'll say incomplete ring. Yeah, probably that.
Something out of the blue. Can it be SSP?
Yeah, I raised the question. I think of SSP, but I think the measles were tested, or
no, that was not tested, but that is okay. Contrast enhancement.
Yeah, that was The contrast was very odd. I think the white matter maybe, but contrast was very odd.
We'll get back once the MOG and the reports. Thank you.
Yeah, thanks. Dr. Vivek also raises GFAP. Yeah, possible if MOG is needed. Yeah, thanks. Okay, Harika, what do you?
So this is another child, 1.5-month-old boy born to non-consanguineous couple, first in birth order. This child had history starting from April. The child had seizures, multiple seizures. So we take to local hospital.
Sorry, Harika, I think I missed your part.
You're breaking up.
Yeah. Okay, so month and a half old with born to non-consanguineous couple, first in birth order, presented with moderate to high-grade intermittent fever for 7 days, all side seizures. The child had 3 sets of scans. I only have the most recent 2 scans. So the child was scanned on 21st of April. I think changes were suggestive of an infective etiology. I have the follow-up scan 4 days later. So 4 days later, diffusion various sequences, you can appreciate subdural empyemas along the bilateral frontal convexities. Going along the falx cerebri, we have hydrocephalus with intraventricular debris out there demonstrating restricted diffusion. Some areas of ischemic changes in the basal ganglia on the left side going up to the caudothalamic groove. You also have exudates in the basal cisterns, the middle cranial fossa out there, and also the posterior fossa CSS spaces demonstrates area restricted diffusion, again, protein-rich contents based on the diffusion signals. On flares, you have diffuse edematous changes, you have verification of circle spaces, hydrocephalus out there, and again, on the flares, you have incomplete suppression of the CSS spaces, hence there is some exudates centered in the basal systems and also in the posterior fossa CSF spaces. Post contrast, you have diffuse meningitis. You have subdural empymas, peripheral enhancement of the subdural connections out there, hydrocephalus. Yeah, so these are the main findings. No obstruction in terms of the flow in the aqueducts or the foramen magnum at this stage, but you have diffuse meningitis, subdural empymas, hydrocephalus, and some ischemic changes on the second scan. The child was extensively worked up. Harika, if you're there, you can just highlight the main findings.
So this child is worked up for meningoencephalitis, for which CSF analysis was done. Protein was 58, glucose 31 with 40 cells, lymphocytes being 80% and neutrophils 20%. And CSF evaluation for TB was done, that was negative. And CSF gram stain was done, that was showing gram positive foci, and culture was sized of MRSA. This was outside report. And when they came to us, we have done emergency Ommaya reservoir placement. At that time, ventricular CSF tapping was done. That was I show protein 260 and sugars of 10 and 180 cells with 90% lymphocytes. And that ventricular CSF analysis was sent for Bactifast NGS. This is next genome sequencing for bacterial DNA that was showing Achromobacter xyloxoxidans. Whereas repeat ventricular CSF culture was done after 5 days, that was showing Burkholderia cepacia complex. Like 3 organisms were isolated from the CSF. And meanwhile, during the course of hospital admission, child had episodes of paroxysmal dystonia with nystagmus. Like child had developed new onset Paid syndrome. So for which repeat MRI brain was done.
Okay, repeat MRI brain diffusion sequences. Again, you have the interventricular debris demonstrated. You have some areas of diffusion restriction in the convexity of the left frontal lobes, some residual subdural empymas along the anterior frontal convexities. Again, you have exudates slightly less in comparison to the second scan. But the posterior fossa, again, you have signal changes in terms of restrictive diffusion, again, demonstrated on this scan. There are some white matter changes, I think, better appreciated on the flare sequences. You have rare factory changes, appearance of the white matter, especially the frontal white matter. Again, these are non-contrast phase sequences, so there are again the circle spaces do not suppress. So there is some abnormalities out there in the meninges. Posterior fossa, again, you have meningeal flare signals, suggest to have again some exudates within the posterior fossa structures. Some microhemorrhagic foci were demonstrated, which was not seen previously along the ventricles, possibly related to the tapping. But yeah, these are the main findings on the follow-up scan with some white matter necrosis and cystic degeneration on the left frontal lobe. In terms of hydrocephalus, I think there's interval reduction in the dilation of the ventricles. Post contrast, again, you can appreciate the meningeal enhancement slightly asymmetrically in the superficial convexities, but again, you have predominant areas of enhancement again in the leptomeninges, basal systems, and the posterior fossa has some areas of enhancement along the lining, the cerebellum, and the brainstem structures. Yeah, I think these are the main findings, and then PID panel was Harika, over to you.
Because of early onset CNS infections and also like persistent progressive neurological course for which immunological workup was done, where PID panel and DHR is negative, and child was initially given IVIG in vivo suspicion of immunodeficiency, but now like child is still continuing to have this paroxysmal dystonia with nystagmus, for which symptomatic treatment is going on. And recently we have done CSF tapping that was showing still proteins of 700 and glucose of 40 with.
Sorry, yeah, I think that's all I have.
So this child ventricular CSF is showing almost 3 organisms.
Yeah, I think all 3 different tests, the CSF gram stain showed gram-positive cocci, which was the most likely etiological organism here. But the gene expert, the PCR had shown varicella, surprisingly, which was obviously not the etiology. And then the NGS had shown the Achromobacter, which is very, very unlikely to cause such extensive meningoencephalitis it's usually a contaminant. So for the neurologists, because we rely on these investigations so extensively, I think it is a constellation of features what we should probably look at. Such a young child, almost like a purulent CSF was there. So we had to go by the gram-positive stain rather than the NGS or the PCR testing in this child.
And just for the Page syndrome, there are no new changes in the basal ganglia, thalamus, or brainstem. Okay, Dr. Vivek says for Page, propranolol and oral morphine to be added.
Yeah, propranolol and clonazepam, the child was on. Morphine, no. The child is currently at home because parents are the care and they're managing at home.
Such a young child with such a severe infection, I think you've rightly worked up for immunodeficiencies, right?
Yeah. So we have asked for the.
The CGD workup and also complement deficiency that is negative.
Thank you.
All right, back to Dr. Ajay further. Dr. Ajay?
Yes, sir, I'm here, sir.
Yeah, thanks.
So he's a 12-year-old developmentally normal boy. He started having focal seizure for last 2 years. No clear etiology behind, no history of any trauma or any fever prior to the onset of the seizures. The reason he was admitted to the hospital because we were doing epilepsy surgery workup because he has been tried on multiple medications and despite that he keep having seizures. So that's the reason we got admitted. And then we'll show you the MRI images, but just from the history, like there was no skin lesions. He was developmentally normal. For the last 2 years, he has progressive academic decline over the course of the time, which you are thinking of because of the frequent seizures. After the MRI, we did a workup including like ANA, lactate, sickle cell disease. Everything came back normal. Cardiac workup was negative. So basically just looking for what can cause this sort of MRI changes and is it still it's safe to go for the epilepsy surgery for the resection of the seizures are all coming from the right occipital head region. And same semiology for the last 2 years, did not have any changes, didn't have any other focal deficits.
All right, yeah, so these are the diffusion and ADC sequences. You can appreciate again some areas of focal abnormalities on diffusion various sequence along the left basal ganglia out there. The cortical regions along the left paramedian occipital lobe demonstrates diffusion changes associated with some subcortical edema, which is demonstrating precipitated diffusion on the ADC sequences. Actually, bilateral changes in the bilateral basal ganglia abnormalities. This focal abnormality does not demonstrate diffusion changes. In terms of parenchyma, there appears to be a generalized volume loss in the brain parenchyma. On SAT sequence, again, you can appreciate the thinning of the corpus callosum, atrophy of the cerebellum, and also the brainstem structures. Flare sequences, you have some additional abnormalities, some subcortical cortical edematous changes in the frontal lobe, in the left parietal lobe of their left occipital lobe. You have these bilateral basal ganglia abnormalities, more predominantly on the left side, and the occipital changes. Again, you have these hyperintense changes on the cortical subcortical region of the right occipital lobe. In terms of SWS sequences, no changes of blooming demonstrated. Angio, I hope the video plays. Angio, if you look at the angio, the vessels are slightly dolichoectatic. There's some ectasia there, some tortuosity. You see, there are some, I think, some collaterals or some tortuous vessels, especially in the perimesencephalic region. And if you look at the circle of Willis, also the vessels do not appear to be what we normally see. It appears to be more tortuous, more ectatic. There is some degree of focal narrowing of the. Let's see if we can put that. Yeah, somewhat over here. If you see, there is some narrowing. Some areas of narrowing, alternating changes of narrowing and tortuosity in terms of the angio. Although MIP sequence, again, you can appreciate these are the slightly ectatic interconnectal category arteries there on both sides, more on the right side. So some vascular abnormality is not in terms of thrombosis, but I thought there is some dolichoeptasia and some stenosis of the intracranial arteries. Yeah, so the question I think we're asking is there are multiple predominantly smaller ischemic changes as seen on the diffusion ADC sequences. Not all of them are acute. Some of them demonstrate different changes. Some of them are completely showing facilitated changes. So as Dr. Ajay has asked, first to look for the etiology, and then if go out for epilepsy surgery. Surgery of the occipital region is. Are you targeting this area? I mean, which?
Yeah, I mean, all the seizures are coming from this only, like the intractal spikes. We did not see any spikes from any other reason. We did not see any seizures. All are coming from this reason only specifically.
Okay. At least it doesn't look on these conventional sequences to be a dysplastic or any connective tissue related abnormalities, Project, given that the arteries are slightly.
There's absolutely no symptoms, like absolutely no symptoms whatsoever. So I was not sure what causing this. Like, it was very surprising to me. I was just suspecting a focal lesion. That's all I was suspecting, and now it came up with this.
And duration is 2 years, not even
2 years. So. Yeah.
And lactate is normal. So
yeah.
No neurocutaneous abnormalities also.
Yes. Yeah.
Okay. All right.
Nihaal, can you show me the basilar artery? Is it okay? That's okay. The other one, this last one.
This one?
Oh, yeah. Where is it at?
This one.
Oh, okay, fine.
It is ectatic. I mean, if you see it slightly ectatic.
Slightly ectatic. Okay, fine.
Yeah. Even the subclavicle is. Yeah.
So it could be cerebral arteriopathy, no? Due to some reason.
Yeah.
Focal cerebral arteriopathy.
But 2-year onset. I mean, yeah.
So probably better off looking for a reason first and treating
I
it
think
before going for the epilepsy surgery, I feel.
Question is, would you go with genetics for this connective tissue disorders, collagen muscular disorders, something like an Alagille syndrome, which has ectasia, stenosis, but I think they have more syndromic features which are lacking in this case. Yeah, so first question is, do you, since it's a 2-year onset epilepsy, do you go with genetics first and then you operate, or what is the approach? Yeah.
But like, do you see like no symptoms? Like something should be there, like clinically examine him. He's a normal boy, goes to school, do everything. Definitely there's decline in academic performance over 2 years. But other than that, you don't see anything physically.
Other areas of the body evaluated for the arteries?
No, only echo was done. Like, so echo, that's pretty much we looked for. I didn't look for any other arteries.
And ocular retinal?
Yeah, like fundus examination was done. That was reported normal.
Okay. I think I would go with genetic, but yeah, I'm open to other surgeons.
I think you should look into genetic and acquired also, no? Immune mediated vasculitis and things like that, and try some immune modulation and all before jumping into.
Yeah, but the only thing is that it's a 2-year process. That's the.
Because maybe if you even if you remove and you cure this boy, the other places might become epileptic.
Yeah, that was the biggest question. Like, we don't have etiology, we remove thing, something else will become epileptic. It's not a good thing to do. So So like, how to stop this thing from happening? I'm just not sure what to do for him.
Yeah, you probably need to look deeper into genetic and acquired causes and try immune modulation and all that before you actually remove this.
Sure. Thank you. Thank you.
Was a PET or PET study done, Dr. Ajay?
Yeah, PET scan study was done, but like it just shows the hypometabolism in these areas. There was nothing like add to that.
So I don't know how do we warrant the resection.
Yeah, that's why I don't want to do it.
Yeah,
that's why we hold it now. Like the seizures were all very, very focused. Same semiology for last 2 years. So for some reason, the seizures looks exactly the same. All of them come from one single spot. We captured 4 seizures. Everything was coming from the very same spot. So
I just had a question.
Yes, sir.
So you have a 12-year-old who's otherwise having no deficits, normal boy.
Yes, sir.
Why are we suspecting infarcts in this?
No, not suspecting, sir. Just based on this MRI, sir.
The only thing is, this is the ADC is there's no diffusion restriction, right?
This centrally has.
Except in the third ventricle, third ventricle area.
This this area over here. Would you consider MELA's possibility, but the lactates are normal?
The problem is all these conditions you usually get deficits. Very difficult to.
The vasculature is definitely abnormal.
Yeah, so there's a condition called arterial tortuosity syndrome, but that again is quite a. This is only the basilar tortuous, so everything is tortuous.
The intracranial arteries are tortuous. I mean, the intercerebral. If you see the circulophullous arteries and also the basilar arteries.
Yeah.
So this is abnormal, definitely abnormal out there. And you have some collaterals also, or some tortuous vessel in the pedibasal cephalic cystons. Yeah, so in fact, a different age group, I agree. So I think we possibly need to go genetics, Dr. Ajay.
Okay.
And then maybe take a call on the surgery part of it. Yeah, Moya variant, yeah, possible. Yeah. So I think next step would be genetics and then.
Sure. Thank you, everyone. Thank you.
Yeah. That's the last case. I have one follow-up. Yeah, monogenic vasculopathies. Yeah, Bulan, thanks. There are a couple of papers on monogenic vasculopathies. I think we'll just share it on the group. All right. Quickly, Dr. Purnima, if you're there, you can just. So this was a case. I think I'll just summarize the initial presentation. There are focal lesions in the brain suspected. We thought of fungal abscess as one of the possibilities. But if Purnima, you can just.
Yes, sir.
Yeah.
A 5-year-old male child born out of non-consanguineous marriage with normal birth and development. He was admitted for 10 days in an outside hospital for fever, cough, and cold symptoms, for which he was discharged with some symptomatic management. During that time, there was no seizure or any encephalopathy documented. And after discharge, 2 days after discharge, he developed excessive sleepiness, headache, vomiting, multiple episodes of vomiting, and he presented to us with one episode of irrelevant talk and excessive drowsiness and confusion. His initial examination GCS was V2, E2, V4 and M3. He was intermittently confused, but he was oriented. Reflexes were brisk, but rest of the examination was normal. He had neck rigidity on admission. His blood workup showed elevated total counts, neutrophilic. CRP was 10 and ESI was 28. Rest of the workup was normal and dengue serology was negative. CSF analysis showed elevated cells, 70 lymphocytes, lymphocyte predominant hai, and protein was only 32. CBNAT was CSF, CBNAT and viral panel were negative. VD demyelination profile also all was negative. Initial imaging.
Okay. Initial imaging, we had this focal lesion out here in the right temporal lobe, posterior temporal lobe, which had areas of microhemorrhagic hemorrhagic foci along the periphery, restricted diffusion again along the periphery, and some very minimal enhancement of the walls. So we suggested that possibility of a fungal infection at that point of time. Spectroscopy demonstrated elevated lipid peak.
Yes, sir.
Yeah. So this was, I think, discussed previously. And
Yes, sir. This child developed left human facial palsy along with left hemiparesis with 2 episodes of seizures on day 7. Till then, with the antibiotics, he had partial response. He improved. We have shifted him to ward. After that, he had left hemiparesis and seizures. And then we have repeated his CSF and the imaging. CSF are more or less same. With 40 cells and imaging.
Yeah, imaging again. Yeah, you had the focal lesion with some areas of again microhemorrhagic foci along the cortex of the temporal lobe and the parietal lobe. And these punctate areas of distributed diffusion in the parietal lobe.
We have started empirically AKT also after this imaging, and we went ahead with biopsy. We could aspirate the pus and the pus culture and pus KOH mount showed fungal elements with septal hyphae, and fungal PCR showed aspergillus, and culture also showed aspergillus. We have started on antifungal. We have started initially with voriconazole and liposomal amphotericin B for 2 weeks. And after 2 weeks, child improved, and neurologically also his facial palsy and hemiparesis started improving. But child had this fever spikes, 1 episode of vomiting and headache. Then we considered to repeat the imaging, and we have sent for voriconazole levels also, which were suboptimal, 0.5. After that, this was the repeat imaging.
All right. So repeat imaging, we had this focal dilatation on the temporal horn, which was not seen in a previous scan. Some periventricular edema, which is there. The lesion in the temporal lobe is, as you have seen, is demonstrates interval reduction. And the main findings were predominantly in the ventricles, the right temporal horn. In terms of SWS sequences, some areas of blooming in the right lateral ventricle, the occipital horn out there, and these cortical changes were demonstrated previously. On the diffusion sequences, we have some area of restricted diffusion within the temporal horn, the ependymal margins, and also within the temporal horn. Also, the adjacent cortex in the middle temporal lobe, and the sulcal spaces out here, if you see on the pyramid and occipital lobes, and some areas of diffusion changes in the ventricles. Post contrast, you have this peripheral enhancement of the temporal horn. I think likely suggestive of some degree of ventriculitis. Given that there's only a dilatation of the temporal horn, maybe it's slightly trapped because of the infection, and these punctate areas of enhancement on post contrast in the parenchyma.
Yes.
And some focal abnormality in the contralateral ventricles, but predominant changes are in the right temporal horn.
We wanted to know, is there intraventricular cyst, or there is the cyst outside the ventricle compressing this horn, and are there any granulomatous lesions in the wall of the ventricle, because it is showing this diffusion restriction, any new and contrast enhancement also in that region?
Yeah, so I think these areas demonstrate previous enhancement, but the main findings were in the temporal horn. I think it looks more like a ventriculitis, which is circumscribed, causing the cessation of flow from the temporal horns. Hence, it is trapped and dilated, is what I think. But yeah, I'll look if anyone has any other suggestions. You see, there's also debris in the ventricles, so
yes,
it goes with ventriculitis.
Yeah. Apart from the imaging, child responded well, and we have to shift his antifungal because of the low-grade fever spikes were persisted. Neurologically, he is doing better, and his elevated liver enzymes. So after discussing with our ID team, infective specialist team, we had changed his voriconazole to isavuconazole IV. We have given overall voriconazole 2 weeks and isavuconazole 2 weeks IV, total 4 weeks. After that, we have shifted to oral isavuconazole. And we have discharged him after 2 more weeks. Now we have plan is to continue for the next 8 weeks, total 12 weeks, and repeat the imaging. And we are continuing the antifungal for 6 months with 3rd monthly imaging we have planned, and galactomannan levels. This was his immunodeficiency panel. It showed a B cell mild deficiency and T cell deficiency.
So any comments on the case management, the new changes?
Duration of antifungal, any other suggestion?
Duration of antifungals is very, very variable in months to years sometimes until we achieve good clinical clearance. And some of these children we have given for 1 to 2 years as well. So very, very recalcitrant, especially when it is in the ventricles, it becomes even more.
Yes, sir. Radiological clearance till that time we have to continue the antifungal and more than that.
So one of the thing is radiological clearance, even like in tuberculoma, sometimes you might have enhancement which is seen, but when you do a PET scan, there is absolutely no activity. So we are using that to actually stop the medication in tuberculomas once you are given for 1 to 2 years. Maybe similar to that, but if your other testing like galactomannan and other things are strongly positive, or the CSF, when you are able to tap and that is showing active evidence of infection, then probably you have to continue for longer.
Yes, sir. Okay, sir. Thank you, sir.
All right. Thanks, Lokesh. Dr. Pena says minimum 6 months is advisable.
Yes, sir.
Yeah. Okay. Yeah, I think we got your answers.
Thank you, sir.
Thanks, Purnima, for the complete case and the follow-up.
Thank you, sir.
Yeah, I think that's the last case. We'll meet again in 2 weeks' time. Thank you, everyone, for your patience and for your contributions.
Thanks, Dr. Nihaal. Good night,
Thank
everybody.
you.
Thank you.
Good night, everyone.
Good night. Thanks, everyone.
Bye, everyone. Bye. See you.
See you. See you. Yeah.